Thank you for APFED for asking me to talk, and I always hate to be the person between you and lunch, but I think this is an important enough topic. So, I was asked to talk about current medications and their side effect profiles, and I think we've already heard all the side effects, and so I think I'll take the time, instead of going through a lot of the listed things, which you can read on the slides, to talk a little bit more about the personal impact. Yeah, and it's not advancing for some reason. That's good. That one. The one that's highlighted. So does it work? Okay. All right. Thanks. Okay, so I have no financial disclosures or conflicts of interests, but I do participate in clinical trials of new therapies for HES. And so in this talk, I hope to review the current conventional therapies for HES, to comment on how some of these work and what types of HES they might be used for, to discuss the most common side effect profiles, but the lists are by no means exhaustive, and patient experience can be very variable for any of these therapies. And so even in ones where we discussed that there's 1,000 possible things, some people tolerate those medications quite remarkably. And then to go over what is actually missing in the current treatment algorithms. So current standard HES therapies that we've discussed already include glucocorticoids, or things like prednisone or Medrol, hydroxyurea that Dr. Gleich filled us in on about, and the historical aspects, interferon alpha, the injectable forms, other immune modulating therapies such as methotrexate or cyclosporin that are sometimes used for steroid sparing. And then the targeted therapy, the only FDA approved medication for HES at the current time. So starting with glucocorticoids. So these have always traditionally been considered first-line therapy for patients with HES, those without known mutations in the current era. And they work directly on the eosinophils, but they have impact on other cell types, including T cells and other cells in the body. And that is in large part the reason for the predictable but very unacceptable long-term and even short-term side effects that require management. And so you can see here listed, and I think I don't need to go into so much detail on the side effect profiles of steroids because we talked about that a lot already. The effects on bone, metabolism, other aspects of metabolism and homeostasis relating to weight gain, effects on fat distribution, development of diabetes, and lowering of immunity at high doses. So there are patients that develop other infections while on steroids. There are the things that, again, maybe we don't tell patients about at the very beginning, things like skin thinning, bruising, that become quite problematic over time. But even small things like muscle cramping and weakness and long-term effects of, not even being able to get up out of a chair or brush your hair and stuff like that that can really impact patients. The sleep disturbance, irritability, and psychosis that can occur can be quite dramatic. And the mood-related side effects are sometimes not as appreciated in the medical community. But the patients experience it quite a bit, and so do their caregivers and loved ones. And as we talked about the effects on adrenal glands, and when we are tapering, the things that can arise in terms of feeling like you hit a wall as you're trying to lower the dose, and then recovering from that, and then lowering again, and then hitting a wall. So those are things that patients describe that are things that we hear about. So interferon alpha is considered often a second-line therapy for HES. We especially consider it for those patients who have a lymphoid type of HES or who have these abnormal T cell populations. The way that we think that it works is by, it has complex action, but one of the ways that it works is it probably inhibits cell growth and proliferation and differentiation. So the cells can't grow and develop and go out into the tissues and cause problems. But it can affect other cells than the eosinophils. And so this is one of those ones where it requires a long visit to discuss the myriad of side effects prior to initiation. But I will say that the thing that affects people a lot is initiating the therapy, and then with any dose changes. So as doses are being increased, the flu-like symptoms, the feeling just, horribly sick and being bedbound and not being able to do the things that people, want to do in their lives, they really put a lot of things on hold. The things that, as physicians we worry about are, what's going to happen to your blood counts and tracking blood, counts and getting labs all the time are very important. But the slowing and the fatigue and the mental fog that patients experience can also be quite profound and limiting in terms of the ability to use this therapy. So there are, black box warnings on this medication for psychiatric side effects, suicidality, having worsening of underlying mental illness, and these are all really well described. But even just things such as basic things as effects on the eyes, thyroid function, and infections, and many, many others. But as I said, there are some patients who actually respond quite well and tolerate this medication despite all the things that we tell them could happen. Hydroxyurea is also a second-line therapy for HES. It interferes with dividing blood cells, including eosinophils, but may affect other blood cell lines. And it's often used in conjunction with steroids or interferon alpha as an adjunct therapy, so we add it on to try to get better effects. And the associated side effects, it's generally a little bit better tolerated, but it can also suppress the bone marrow, cause skin changes, including pigmentation changes, effects on hair, abdominal side effects, and also secondary malignancies have been reported with these drugs. But a lot of people take them and have done okay. Then going to some of the immune suppressive medications, so methotrexate is one that we reach for when we can't lower the therapies in particular types of HES, and that includes patients who have something that we haven't really talked about but is considered one of the HESs, patients who have overlap syndrome with hypereosinophilic syndrome, where they have some features of something called Church-Strauss, or EGPA as it's now known. And so when we're having problems lowering the steroids, we may initiate this therapy, and it can be given either orally or as an injection weekly if the GI side effects are intolerable. And it prevents folate metabolism, and it interrupts cell replication. And so we have to give folate supplementation to reduce the side effect profile. This is a medication that's given in the rheumatologic field for things like rheumatoid arthritis and other rheumatologic conditions. And so there's a wealth of experience using this medication. Some people tolerate it quite well, but others have a lot of side effects. And sometimes that also impacts the dose that we can give and inability to raise the dose to try to get the effects that we want from a medical standpoint. And some of those side effects, again, are listed here, but include gastrointestinal symptoms such as nausea, vomiting. Serious infections can occur at higher doses, bacterial, viral, fungal infections, and also needs monitoring, like a lot of these medications, for liver side effects, pulmonary side effects if people develop cough while on this medication, and also secondary malignancies. So all of the immune suppressive medications have the potential for other side effects, including infections and secondary malignancies, and so that's a problem. I won't talk too much about imatinib. This is really now used for patients who have a myeloid type of HES, who have the mutations PDGFR-A or B, but we do use it sometimes in patients who don't have the mutation but have a clinical syndrome that looks like that. And it's generally well tolerated, but may have other side effects, including skin and nail changes. Patients can develop swelling or edema in their legs, and there are other listed side effects, but I don't want to go too much into it. And then there are many others, and this is really where the art becomes in play when we do the standard therapies and they either don't work or their side effect profile are intolerable and a patient doesn't qualify for an active trial. You know, there are other therapies such as Cellcept, cyclosporin, you know, big guns like alemtuzumab or antibodies that have much more profound effects on the immune system. And then there are some medications that have, you know, there's small case series or case reports such as JAK inhibitors that have been used in small numbers of HES patients and other therapeutics. And as one panelist mentioned, you know, there is always the possibility of need for a bone marrow transplant, and some patients with HES have had bone marrow transplants because of intractable disease. So what are the main issues? So they're the things that we perhaps don't really focus on, but are truly major issues for patients. And these are effects on fertility or development of the unborn fetus when using some of these medications. Many of the current therapies are harmful during pregnancy and have, you know, pregnancy category X, which essentially means there's data that suggests there's harm. So that's a concern for those patients who are of childbearing age or potential. And as mentioned, some of these medications also have sexual side effects. And again, those things, if we're not discussing with our patients, can be a problem in terms of choice of medication and desire to continue with various therapy. There are interactions with lactation, effects on daily functioning and quality of life. The need for monitoring and frequent lab draws can become quite profound. There are drug-drug or drug-food interactions that we all need to be aware of when we're instituting some of these therapies. You know, as mentioned earlier, you know, the lack of a defined indication, not having FDA approval for some of these medications, which, you know, can work quite well for patients, is a real big problem. The resultant cost or lack of approval by insurance. And I guess I just wanted to reiterate what Dr. Amy Cleon had said earlier, that there are, you know, gateway programs through GSK or copay assistant programs through AstraZeneca for the current available therapies that are being used for asthma. You know, we always like to caution that we don't know whether those medications will work for HES per se, although people are starting to do that out there. And so we're hearing from allergists and other doctors that they've tried this medication and it might work for some patients, a subset of patients that have a more milder phenotype of HES. And then in addition to the copay programs, there are also disease foundations that help with copay assistance. One of these is the HealthWell Foundation, where they actually have disease that they partner with to give a certain amount of medications for copay assistance or helping with cost of drugs. And so those are things that might be explored. And then finally, lack of efficacy. And so here, this was the study that was referred to by Dr. Gleig that was performed by Princess Ekbagu and Amy Cleon at the NIH. That was a retrospective study looking at a whole host of patients from multiple centers and looking at the response to therapy. And highlighted in red, these are patients that had to stop drug because of a various lack of efficacy. And so you can see from prednisone to hydroxyurea, all the way even anti-IL-5, there were patients who had to stop therapy. And so really the issue is that knowing patients and what's going on with them is really important. And I think Dr. Cleon is going to go more into that, so I won't talk about that so much. But I guess sort of turning the focus, there's been an explosion of new products out that are being studied for eosinophilic associated disease and in some cases HES. And these range from drugs that are currently available for asthma right now, so mepolizumab, breslizumab. And mepolizumab was also recently FDA approved for EGPA at a higher dose than the asthma dosing, so it's 300 milligram dose. And so for patients who have an overlap type of HES, they could try that through an FDA approved indication. There are receptor agents, so benralizumab, which binds the IL-5 receptor and targets the cells for killing by other immune cells, or dupilumab, which is actually not used for HES, but is being looked at in other eosinophil-associated diseases. There are inhibitory receptor targets, so One of these is called Siglec-8, which basically targets eosinophils and mast cells for killing, and those are in early phase or have been studied in early phase studies, not for HES, but the potential is perhaps there. And then there are other targets that we don't know the mechanism, perhaps, and also have more downstream actions, such as dexpramipexole and JAK inhibitors that may play a role in the future. So I discussed the standard HES therapies, but I'm hopeful that really we're at a point where we can start to connect patient-level data, different subtypes of HES, to tailor therapies by using drug development and the new biologic therapies to really learn more about the phenotype of patients and figure out which patients might respond to various therapies. And so it's really been an evolution of HES over time from what Dr. Gleich described to now really trying to think about which patients might respond to which therapy and actually harnessing the potential of research to answer some of these questions. And so I wanted to have one historical slide, so nobody asked me to talk about history, but I like to sometimes. And this is the antibody initiative, and this slide was taken from the National Museum of American History. And I guess it really shows where we've come in terms of immunology and therapy. So these, they catalog the original serums that were used for therapies, all the way to things like interferon and the development of monoclonal antibodies. And I think it's hopeful for us who take care of patients with rare disease that there may be better targeted therapies in the future that will help with a lot of these side effects and problems. And I'll be happy to take any questions. I think you have to talk so that other people that are online can hear.
If something is working, is it likely to continue to work in the future?
So that's a tricky question. There are patients that break through therapies. So with various of these medications, there may be development of anti-drug antibodies. Patients who have historically responded to prednisone can sometimes require higher and higher and higher doses. So there's a lot of things we don't understand about, you know, whether something's going to work today is going to work 10 years from now. But, you know, a lot of patients where, you know, have been treated with these biologic therapies for, you know, up to a decade and continue to do well. So, you know, we think that some of them are fine, but there's a lot yet to be studied. So I can't speak to each one, but some people are. I mean, I have one patient who's been on methotrexate injections for almost a decade, and I keep trying to tell him to come off, but he's too afraid. So I think sometimes not knowing whether somebody's cured or whether the disease is completely, you know, in remission and trying to taper it is important. But to answer your question about whether, you know, it's likely to continue to work, you know, in some cases, yes, and it just requires monitoring like all things with HES.
We have a question that has come in from online, and it is about the spectrum of hypereosinophilic syndrome and exactly how one diagnoses that. The question relates to this woman's husband who has high eosinophils in his blood, esophagus, and lungs, but does not have a diagnosis of hypereosinophilic syndrome and has normal bone marrow. Is there a spectrum of hypereosinophilic syndrome that falls short of the diagnosis criteria that Dr. Gleich showed?
So I think the spectrum is what characterizes hypereosinophilic syndrome, that somebody has an elevated blood eosinophil count and tissue involvement. So I think, you know, not having seen the person, and we're not giving medical advice, but it sounds like that potentially is hypereosinophilic syndrome. You know, the fact that the bone marrow doesn't show eosinophils, you know, sometimes there's a, you know, the eosinophils have been pushed out of the bone marrow and now they're in the tissues. And so you're detecting eosinophils in the tissues, you have an elevated blood count. I think that's likely the diagnosis, assuming other things have been ruled out.
All right, I'm going to hand the mic over to Amy, but if anybody has questions they don't want to ask on the mic but want to write down, pass them to me as well.
Hello.
Hi.
What's your thought and the panel's thought on medical marijuana? We have two sons that have eosinophil disorders. Our youngest, he's 22, he has HES, leukemia, and our oldest, 24, has eosinophil esophagitis. Now, our oldest, he's come to the point now where he's self-medicating with marijuana because he feels that's what he needs to do in order to eat. And he started out with oils probably about 3 years ago, and he said it helped. He kind of looked online and talking to different people and saying this would work, and he's tried it, and he feels that's the thing he needs to do. Because he said, last time he was at the doctor's, he said his only option now would be a feeding tube, which he's determined not to do.
So for the eosinophilic GI disorders, there's, a sort of multidisciplinary approach, and some of those things involve dietary therapies. And assuming that all of the things that would be standard have been worked on, we don't have much data on medical marijuana and what it might actually do in patients with eosinophilic disorders. But as you heard, there are people that are probably doing these things. So I don't have much experience in that, and I can't really comment on it. Yeah, I think you should talk to the people that are doing it, perhaps. It's not something that we recommend. There is an approach for management and treatment of eosinophilic GI disorders, but clearly there are people that are much more severe on the spectrum of disease and start taking matters into their own hands. And so it sounds like a little bit of that. But I would ask you to, ask around and see who else is perhaps doing that, but it's not something that we recommend.
Dr. Khoury, with respect to the monoclonal antibodies, do you see many instances of a rebound effect where initially it's very successful, but then later it comes back, the eosinophil counts come back perhaps worse than before? Is that something that happens or not?
With stopping or with continuing?
With continuing.
Okay. So generally people who have it depends on which monoclonal antibody, and it's very variable of type. With the anti-IL-5 therapies, with continuing, if there's a response, generally people continue to respond. But there are always exceptions. And so we have seen people who their eosinophil counts start to climb and we start looking for anti-drug antibodies. With the anti-IL-5 receptor agents, there are perhaps people that don't respond, and also people that might relapse after being on those therapies. So it's really matters what type of HES the person has and what the biologic. So I can't give you a general answer, unfortunately.
One of the questions that I have was about the triggers. Could it be food triggers or environment triggers? Because you always feel like all of us, you're okay, and all of a sudden you develop an angioedema, or you started having urticaria or whatever, and you want to be able to link it to something that you ate or breathed or, whatever attitude. What do you have something to say about that?
So we don't have there's no known food trigger for a hypereosinophilic syndrome. Now, there are some people that might have associated GI conditions that they do develop immediate symptoms from food in the context of HES. There are also people who complain of seasonal variation with some of their eosinophilic processes, again, usually mostly gastrointestinal. Now, whether there's something that may also trigger eosinophils or mast cells in people who are predisposed to those things, it's not very clear, it's not been studied. But, with all these things, it's possible. I don't think it's our most likely thing to go to. So as an allergist, when somebody has a true food allergy, it's pretty clear that they have very specific findings with each time that they're exposed to a food. And I think in HES where we struggle is that everyone wants to find something they can do themselves that doesn't involve all these drugs with side effects. And so I think there's always, the personal bias, and, we all do this. We're human. We're going to try to see if there's something that I could do to try to prevent this from getting worse. And so I think we can drive ourselves crazy trying to look for that. And most of the time we don't find something like that in HES that is a trigger. But if you speak to people, you will find that there are various other triggers, emotional things, or maybe even just the way they feel at a various time, or they're sick for some other reason, that people then do start developing other symptoms. And but we don't have a specific thing that we tell people to avoid.
Actually,
Oh,
sorry.
yes.
Yeah, I just had an observation about triggers. So obviously my daughter, her body's making eosinophils, we don't know why, but her the symptoms was manifesting in her sinuses, completely blocked, and in her lungs. We found a physician who had been at the Mayo Clinic for a number of years. You're probably familiar, and worked with him and got treatment through him. My daughter had a sinus surgery to clear out this diseased tissue. She's doing an antifungal rinse because she has a variation of a type of an allergy. It's a non-IgE mediated response to a fungus. And she's been on amphotericin B just as a sinus rinse for 2.5 years, and she's had no recurrence of the polypsosis and the sinus issues. So it's been pretty dramatic. Right. He's developed specialized slides or methods of collecting mucus and detecting fungus. He's got a patent, and he was at the Mayo Clinic. He did all this work. Anyway, so he came up and was able to document this for us. So, there's some discussion of whether or not that's accurate. But in my daughter's case, it's actually resulted in a really good outcome.
Sure.
So
and so there's a known entity of allergic fungal sinusitis, and clearly if there's a fungal trigger, that might be possible.
Paneez, Jerry Gleick here. Just a quick question. Well, you've been talking, I've been texting.
Okay.
So I was communicating with a patient who I've been taking care of since about 1980. And this patient had a variety of problems, but recently went on the paleo diet. Mm-hmm. And she is convinced that has permitted her to stop utilizing interferon after almost 30 years.
So do you have evidence of that? I mean, are they off interferon and no longer eosinophilic?
Her eosinophils remain in a normal range.
Off interferon?
While off interferon.
For how long?
2 months.
Okay, that's pretty short.
Should I encourage her to go back eating gluten?
So patients can go into remission on interferon unrelated to the food diet, right? So we see patients who've been on interferon for many years, and we're able to start tapering their doses for unclear reasons, and then all of a sudden they're off, and sometimes patients remain off and go into remission, and they don't do food things. And so I think it's hard when you're making two different clinical interventions at once to prove that. But separate from the interferon issue, there are some patients that do feel much better on various diets. And so I have patients who are on low FODMAP diets or paleo and do exclude things and say that they feel much better. And from my perspective, if you can maintain that for your life and you are feeling much better, there's no harm in that. And a lot of patients with eosinophilic GI disease do already restrict their diet unrelated to any testing, just based on how they feel, and we all do that. So I'm not certain that we need to jump on certain bandwagon of a specific diet, but there are probably some anecdotal cases that might describe what you mentioned.
One last comment. While flying here yesterday, I was reading about the effect of, or the difference in responsiveness to the programmed death antibodies that are used to treat various malignancies, and the relationship of that to intestinal gut bacteria. Mm-hmm. And that, 3 articles in Science claiming that.
So I wonder the PD-1 antibodies and
well,
the
yeah,
microbiome?
there were correlations between the responsiveness to the antibodies to PD-1 and the occurrence of different bacteria.
Right,
That's
and so we know, so
tough.
clearly, there's a lot to be learned on the microbiome, and that's, the normal gut bacteria. And people are looking at that in the context of eosinophils, especially in eosinophilic GI disease. And diet plays a remarkable role on your normal gut bacteria. So that's been also described in, Science or Nature, I can't remember where we read that, but, transit time through the gut and what people are eating might have an impact on the microbiome. Now, whether the microbiome has an effect on the eosinophils and HES is not clear. But clearly that would be a very interesting approach to look at.
I suffer from severe GI intestinal problems from my HES, and I know you had mentioned that there are no known triggers, but have you ever seen other patients that start with several food allergies and end up with dozens of allergies to the point where, like I'm at, I've done full, complete gut rest for months and nothing changes. My symptoms continue to worsen. We tried to do a J-tube, but I was allergic to all of the formulas, so that failed. Obviously, TPN isn't a long-term answer for me. Eventually, I will have to eat food again, but my list of allergies just continues to grow and grow and grow for no apparent reason.
Right. So, so I think it's tricky because defining allergy. So, eosinophilic GI disease is not a classical allergy where you're feeding somebody peanut and they anaphylax, but some people can have localized allergic reactions in the gut that are maybe a slightly different mechanism. But a lot of our thinking is that it's the chronic exposure to the different foods that makes this much worse. And that, I think this is very much different than HES in general. So when we talk about eosinophilic GI disease, so that is a known entity that food antigens can be triggers. And some patients do end up on the really elemental, hypoallergenic diets, and that's what you're trying. So that's usually our recommendation to try to heal and get things more under control. But it is a long process, and I think working with people that are familiar with these sorts of things, and trying to slowly introduce things that are least likely to be allergenic, but some people do really end up on very limited diets, and it's very frustrating. So we understand your frustration and difficulty with this disease, and I think that's where the hope is that some of these new medications might have impact on them. So I think there's a lot yet to research and understand about what actually is causing it, whether it's really just the eosinophils or if it's other cells in that are playing a role. So. But yeah, people can develop new allergies. No, that's a known entity, and even in classical allergy, you avoid a food for a long period of time. Somebody can actually become truly allergic to something that they were avoiding because of symptoms, but then develop a true IgE-mediated allergy to foods. And patients with EGID can have problems with worsening numbers of foods in their diet.
Onions, prime example. I ate onions my entire life. I have not eaten onions in almost 2 years, and now the smell of cooked onions causes an allergic reaction, a severe allergic reaction. So I haven't eaten them in forever. So I guess I'm just confused as to why my body is all of a sudden reacting to these things where. Yeah.
So we always caution when we start telling patients to avoid things that the reintroduction might actually be worse, and that may be the case for you.
Thank you, Dr. Khoury. That was fabulous. We are going to break for lunch, and lunch is in the Madison room next door, which I believe is where breakfast was. And Mary Jo's pointing in the back, so if you need to find food, follow Mary Jo. She'll point you in the right direction. We are coming back at, I believe it is 1:20, and we come back, we're going to focus on new therapies for hypereosinophilic syndrome. Thank you.